Hi, I'm Sarah Ozel Shore. I am a psychotherapist and clinical trainer. And I have spent the past 15 years developing the clinical discernment framework, which teaches clinicians how to improve clinical effectiveness by assessing for certain client capacities during each session. And today I'd like to talk to you specifically about what the difference is between a client having a genuine insight and a client being ready to integrate that insight. So, sometimes it's the case that distinction um, doesn't really register for us, but it actually matters, and it matters a lot. Um, this distinction is one of the most consequential in our work, but it's also not directly taught that often. Insight and the capacity to integrate insight are not the same thing. A client can genuinely see something, can articulate a pattern, can recognize a connection, can name something real about their experience, and still not be in a state where they can do anything about it. In other words, where it can reorganize their behavior or shift their self perception or produce lasting change. What differentiates an insight that consolidates from one that dissolves is not primarily the accuracy of the observation or the depth of the recognition, but it's whether the conditions for integration were actually present in the room in the moment that the insight appeared. So, if we get really specific, was the client's nervous system sufficiently organized to hold what they had just seen or heard? Could they stay with the recognition without becoming overwhelmed or retreating from it? Could they reflect on it rather than simply producing it? Was the insight arising from genuine reflection, or was it a kind of verbal performance of insight? We've all seen clients that can say the right words in the right tone, but there's something that's missing. There's no felt reorganization underneath it. It doesn't feel like an aha that integrates. So, when integration is not possible, when the client produces insight, but he or she lacks the regulatory conditions to hold it, what you observe is a pattern, a particular clinical pattern. Clinical work that seems productive in session resets almost completely between sessions. The client returns the following week, and what felt significant the week before is either forgotten, dismissed, or it's present as an intellectual memory, not an embodied memory. There's no felt weight attached to it. They can recite it. That's not resistance in the conventional sense. It's not ambivalence about change. What it is a state dependent phenomenon. The insight was formed in one regulatory state, and when that state changed, the insight became inaccessible to the client. So the nervous system that produced the insight is no longer the nervous system the client is living in during the rest of their week. So when we talk about integrating insights, it's really about integrating nervous system states. And that requires that your clients learn what it means to actually return to a regulated state. So, regulation is the first of 6 capacities that the clinical discernment framework addresses. Because without it, the others can't be accurately assessed or reliably worked with. If you want to go deeper into this, I will be offering a clinical training called Why Good Interventions Fail, Assessing Regulation in Real Time. Because insight without the prior requisite condition of a regulated nervous system does not carry forward and does not integrate and does not create change. But we can become more effective as clinicians when we slow down, use restraint during our sessions, recognize dysregulation when it begins, and work toward re regulating the client so that any further work done in that session can actually integrate. I'm Sarah Ozel Shore, and I'll see you next time.